So, good evening, everyone. Welcome you all to the academic session, classroom session of Spice Route India Movement for the month of March, being hosted by Spice Route Kerala chapter. And we have a pediatric case presentation that's happening today, and the presentation is from Luz Hospital, Kochi. The presenter for today is Dr. Unaizat, and she's a final year family medicine resident at Luz Hospital. And the chairperson for today is Dr. Yashmi Saim. Ma'am is the head of the Department of Family Medicine at Ruth Hospital, and she's a renowned academician in the field of family medicine in India. And I would like to hand over to Rashmi ma'am to proceed with the session.
Good evening. Before Unaizat starts the case presentation, I would request everyone to be active in the chat box because the questions will be to everyone, not just to Unaizat. So please, this is for everyone's benefit. So please, as and when questions are being asked, kindly type in the chat box so that you can also get involved rather than listening passively to the case presentation. Okay, so this case will look simple from the outside, but always an exam case for all of you. So, Unaizat, carry on.
Okay, madam. Good evening all. I am Dr. Unaizat, final DRB resident, Family Medicine, North Hospital. Here I am presenting baby Nicole Paiva, 1 year old, 1 year and 8-month-old baby boy. He is coming from Chittoor. He is the second born out of non-consanguineous marriage. Is belonging to a upper middle class family. Mother is the informant and information is reliable. The date of admission is 15 March 2024 and date of examination is 16 March 2024.
Okay, Unaizat, 1 second before the next slide. Can someone tell me why she said that the information is reliable? What are the things that you look for when you say that the information is reliable? Is always the mother's information reliable, or when do you say that the information is reliable?
Informant should.
No, let us wait if somebody is typing on the chat box. If not, Unaizat can answer. Should stay with child for how many days? Yesterday? Or mother is mentally sound, then? Okay, Unaizat, we can't waste time. Okay. When is the information said to be reliable?
Informant should be mentally sound. He should be informant should be stay with the patient.
Staying with the child during the period of the illness.
Period of
and also the education level also of the informant is important. Okay, some of the information might not be possible if the informant is totally illiterate. Okay.
Okay.
So, okay, move on to the next slide.
Now we are going to presenting complaints. Child is presented with cough and running nose for 4 days, fever for 2 days, and noisy breathing for 1 day. Now history of presenting complaints. Child developed cough 4 days ago, which was dry initially, later become wet. There was associated post-office vomiting, 2 to 3 episodes with vomitus containing food particles mixed with sputum, which was not blood-stained or foul-smelling. No diurnal or postural variation for cough. Child also had watery nasal discharge, which later became mucoid in nature. Child developed fever 2 days later, which was high-grade with shivering. No diurnal variation and was not subsiding completely with medication. In between the fever spikes, child was active. 1 day later, child developed noisy breathing. Along with that, mother also noticed that he is breathing fast and there was indrawing of chest along with the noisy breathing. The child became less active since then with increased tiredness and poor oral intake.
Okay. Let's stop it here. So have everyone got all information about the cough? Now, anything else you want to ask about the cough? Not about the fever. Fever, we'll discuss in detail later. Anything more you want to know about the cough? If nothing more, I'll ask her to proceed to the next slide. Is everything clear? The onset of the cough, how many days back? How was the cough? Any variation, diurnal or postal variation? Whether there was sputum and whether the sputum was blood stained, post-acid vomiting associated with nasal discharge, and later developed noisy breathing and fast breathing with indrawing of amount in a 1 year and 10-month-old child. It will be difficult for nighttime cough. She said there is no diurnal variation, so maybe not increase during nighttime. So it would be same throughout. That is the same intensity. Yes, nighttime cough is important. Amount is not possible to elicit in a small child because most of it will be swallowed only if the post-acid vomiting comes, some sputum will be there. This is only till 2 days, so 4 days. So there is no, we cannot ask about seasonal variation also because probably she'll come into the past history that is saying that this is one of the first episode. This is the first episode. So wheezing, yes, you can ask whether there was any sound, musical sound while there was when the child was breathing. That was not there. If it was there, she would have mentioned, I hope. So yes, these are the things that you want to know. Yellowish discoloration of sputum, because the sputum was mixed with food particles. It is very difficult to elicit the color and all in a 1 year, 8-month-old child, I think. A bigger child or an adult who spits out the sputum, we can get the color. What is the significance of yellowish discoloration of sputum? Are all yellowish sputum bacterial infections?
No.
There is a misconception that when the patient says that the color of the sputum is yellow, we all of us tend to think, oh, it is bacterial and prescribe an antibiotic. No, never. Yellowish does not equate to bacterial infection. So actually it doesn't have much relevance, but still, and even then in a child, it is difficult to elicit that history also. Okay, now before she moves on to the next slide, what all will you know? What all will you want to know about fever in this child? Someone please type fast. What all will you want to know? There is one localizing feature for the fever, that is cough. So you can think that there is some respiratory problem. But to exclude other systems or to get more information on the fever, what other questions would you like to ask? 30 seconds, please type fast. Okay, pattern of fever, loose stools. Okay, onset of the fever that she said. Duration, okay, does it touch baseline, subsides with antipyretics? She said that it is just subsiding with, it doesn't subside completely with the medication, means it doesn't touch the baseline, maybe. But when medications are given, it is difficult to tell about the intermittency or remittent fever or whatever. Okay, incessant crying, rashes, crying while urination, very good. Loose stools, chills. Yes, she said there is shivering with that. Okay, so we'll move on to the, okay, very good history of seizure, urine output. So we'll go to the next slide, Unai sir. Unai sir, next slide.
Oh, okay. There is no history of aspiration, no history of bluish discoloration of the body, no history of redness of eyes or incessant cry, no history of altered sensorium or abnormal movements, no history of ear discharge, drooling of saliva or stridor, no history of cry during micturition, decreased urine output, no history of abdominal distension or altered bowel habits, no history of any rashes, no history of recent vaccination, no history of contact with the person with the fever. Baby is admitted for last 24 hours and febrile for last 12 hours, and fast breathing and noisy breathing improved with the medications and nebulization.
Okay. You got all information, or anyone wants to ask anything else? Why was the history of aspiration and bluish discoloration of the body asked? Decreased activity and oral intake, she already mentioned in the previous slide. In the previous slide, in between the fever spikes, the child was active. And only since when the noisy breathing started, there is poor oral intake and decreased activity. Only after the noisy breathing started for 1 day. So why was aspiration asked? Because of the cough and breathing difficulty, to know if there is an acute cause for the breathing respiratory distress. Why was bluish discoloration of the body asked? Hypoxia. So what are the, according to IMNCI, what are the danger signals that you will look in a child that you will ask in a child who comes with fever or any other complaint? What are the three or four things that you will ask initially to assess the child? Okay, lethargy, then all that she has mentioned, that is bluish discoloration of the body, the cyanosis, very important to be asked. Feeding, okay, poor feeding. Unable to take feeds, that is vomiting, always, vomiting feeds or unable to take feeds. Then chest indrawing, fast breathing and all associated with the cough. Any patient who comes, any child who comes, something else very important. Yes, very good. Seizure, convulsions is one danger sign in IMNCI. So all these points she has mentioned already. So she has ruled out most of the other systemic causes of fever, and also mentioned that there is no recent vaccination. Okay, playful. She said that the child is active in between the episodes. Only since the last noisy breathing 1 day, the child is less active and poor oral intake also. And after admission, the child has improved with medications and nebulization also. Two important things, that is recent vaccination and contact with person with fever, because usually children get fever from some other family member who has fever or respiratory infection. Now go to, so present history, is it over, Unaisat?
Yes, ma'am.
Okay, so go on to the next slide.
Now moving to the past history. There is no history of episodes of cough with breathing difficulty which required hospital admission in the past. No history of any previous hospitalizations. No history of vaccine preventable illnesses. No history of any congenital heart disease.
Which are the vaccine preventable diseases you will ask in this 1 year, 10-month-old child who has who has now come with respiratory infection? What are the vaccine preventable diseases that you will think of?
Measles.
Yes, measles.
Pertussis.
Influenza.
Any bronchiolitis.
TB, okay. Bronchiolitis. Pneumonia, okay. Pneumococcal pneumonia. Okay. It's influenza, that not the influenza virus, because we don't give vaccine usually in the national immunization schedule for influenza virus. This is H influenza pneumonia that we are giving vaccine for Haemophilus influenza infection to prevent Haemophilus influenza pneumonia. That is what is HIB. Okay. The other viral influenza vaccine we don't give in the national immunization schedule. So we have to ask about any vaccine preventable illnesses in the past, any congenital heart disease. Which congenital heart disease specifically can cause recurrent respiratory infections?
VSD.
VSD. Okay. So move on to the next slide.
Now antenatal, natal and postnatal history. The child is born as a second child of non-consanguineous marriage. It was a spontaneous conception. His elder sibling was 2 years older. Mother had regular antenatal checkup during the antenatal period. She was taken folic acid, iron and calcium and taken booster dose of tetanus toxoid. There is no antenatal complications. Natal history, he was born by elective lower segment cesarean section. Its indication was the previous lower segment cesarean section, which was done at 38 weeks of gestation. He was born with a birth weight of 3.6 kilogram. Now, postnatal history, he cried soon after birth and put on breastfeeding after 1 hour of the delivery. No history of neonatal resuscitation. Urine passed within 48 hours and meconium passed within 24 hours. There is no history of neonatal hyperbilirubinemia or neonatal seizures. No history of any NICU admission.
Okay, carry on. Nothing significant in this. Okay, carry on.
Developmental history. Child attained all milestones appropriate for age. No history of any developmental delay. No baby walks well and
Unesat, 1 second. Please go to the previous slide. Yeah, now somebody can type the gross motor, fine motor, language, and social milestones that you expect in this 1 year, 10-month-old child. Gross motor, what all do you expect? Gross motor in a 1 year to a 10-month-old child. Stand without support, running, walks. What is GN? Gross motor, okay. Walking and running. Running how many marathon? Walks with support. Okay, okay. Enough of gross motor. Now fine motor. 9 feet per step of stairs, okay. Then stand without support. Now fine motor. Scribbles, okay. Pincer grasp will be attained long back. Then copies parents in task is domestic mimicry. Nature pincer grasp. Tower of 2 or more. Scribble, okay. Language. Yeah, 3 to 4 cubes. Language. Okay, language 2 to 8 words with meaning. Simple sentence at this age. Difficult. 8 to 10 words. Okay. 8 to 10 words. Okay. 50 words at this age. Okay, Vanessa, go to the next slide. Now we'll see what all this child does.
Developmental history. Now baby walks well and started to run and climb upstairs with 2 feet per step. He can feed self from cup and with spoon and makes tower of 3 to 4 cubes, and he can scribbles and child is right-handed. He says around 10 to 15 meaningful words and knows some body parts. He got potty trained and has bowel control at day and shows domestic mimicry. He has not day by day, occasional waiting at daytime. He is using glasses since last 2 months. It is because mother noticed that child could not see things from distance and was evaluated by an ophthalmologist and using glasses now. Hearing is normal.
Okay, so in this, almost all milestone, or not almost all milestones are adequate, except that vision, he has some problem which was evaluated and some glasses was prescribed, probably because they say that he cannot see things from distance. It could be myopia. So he was prescribed glasses. Other than that, the development history is development is appropriate for age. How do the mother know? How can we ask the mother whether the milestones are appropriate for age? How do we get that? Because how does the mother identify that? Identify if the milestones are delayed? How can a mother identify? Yeah.
While comparing to a similar
Yeah,
same
comparing
age.
to either the elder siblings or to other children of same age.
Same age.
Comparing with other siblings in the family or with other children of same age. Okay, go to the next slide.
Now dietetic history. He was exclusively breastfed up to 6 months and complementary feeding started at 6 months with ragi and banana powder and put on family diet since 8 months of life. There is no history of food allergies. His diet includes fruits and green leafy vegetables. His breastfeeding is continuing till now.
Okay. Okay, next. Next slide.
Now he gets 930 kilocalories and 24 gram proteins, which show that he had 106 kilocalorie deficiency in calorie and his protein intake is adequate.
So how do we calculate the calorie and protein intake in a child? How do we calculate? No, you don't tell. Somebody can type. Okay, 24-hour diet recall you have to ask, and then from that you can calculate the. So when you go for exams or whenever this is just a tip, when you go for exams, you should know what is the diet of that area where you have the exam. Or if you're working in your own place, it doesn't matter when you practice. But exam, when you're going to some other center, you should know in that state what is the common food. You cannot ask what you are familiar with. So you should know the common common foods. What is the caloric value and also how much protein is there. And with the 24-hour record, we are calculating it. So in this child, it is almost adequate. Just a little bit of deficiency in the calorie, maybe because the 24-hour record, this one 24-hour, maybe he was having fever and cough, maybe because of that. Okay, go to the next slide.
Now immunization history. Child is immunized up to age according to national immunization schedule. BCG scar is present. There is last vaccination was at 18 months of life with the DPT first booster, MR2 and OPV booster. No optional vaccines taken. Pulse polio was given at last month.
Okay, wait. Now, what are the, you already said about those. What are the vaccines included in pentavalent? Somebody can type. What are the vaccines included in the pentavalent vaccine? And when is it, what is the dosage? I mean, what is the schedule of pentavalent vaccine? DPT, hepatitis B and Hib. Okay, when is it given? DPT, hepatitis B and Hib are correct. When is it given? 6, 10, 14 weeks. Okay. Okay. So when is rotavirus vaccine given? Rotavirus vaccine, when is it given?
6,
Okay,
10,
again 6, 10, again 6, 10, 14 weeks itself. Okay, what about the polio vaccine schedule in national immunization schedule? What does the national immunization schedule recommend? Polio vaccine.
Birth, OPV 0 dose at birth and OPV
Okay.
1, 2 and 3, 6, 10, 14 weeks.
Okay.
Booster at 16 to 18 months.
What about the
18 to-
fractional IPV?
IPV at 6 and 14 weeks.
Yes, fractional IPV at 6 and 14 weeks and OPV 0, 6, 10. Till this, for this child's age, 6, 10, 14 weeks, 0 dose and 6, 10, 14 weeks and then again at 18 months. Okay, what about the,
18 weeks.
which is the vaccine used for pneumococcal?
PCV 13. PCV 13.
Okay, PCV 13. What is the other vaccine available for pneumococcal vaccine, which is given in adults? PPSV 20. But in
PPSV 23.
for children less than 2 years, we are giving PCV 13. So in the national immunization schedule, it is PCV 13. For adults and children above 2 years only, PPSV 23 is recommended. Okay, so what are some of the optional vaccines you can tell to this child? Hepatitis A, okay. Influenza, okay. Annual influenza vaccine, okay. Chickenpox vaccine, varicella vaccine, so that is chickenpox vaccine again. Typhoid vaccine, okay. Why do we give pulse polio? Why do we give pulse polio in addition to the routine schedule of polio vaccine? Yes, herd immunity. It is to develop herd immunity. Okay, good. Next slide.
Now moving to the family history. It was a non-consanguineous marriage. There is no history of tuberculosis, bronchial asthma, or congenital heart disease in the family. There is no history of child with congenital malformations or intellectual disability in the family. He has one elder sibling, his 4-year-old boy, normal child, no recent history of respiratory tract infection for the elder sibling. His mother's brother had visual problem since childhood and using glasses for same since childhood. Yes.
Okay, so
Possibly
all of you
myopia.
possibly myopia. Okay. All of you should know how to draw the pedigree chart. Okay. Because for exam, it is very important. You have to draw 3-generation pedigree chart in the exam also. Okay, move on to the next. Why did we ask about the elder sibling having? Because usually it is the elder sibling who goes to school, who gets the respiratory infection, and then the younger sibling also gets, or anybody else in the family getting respiratory infection is usually the source for a child to get respiratory infection. Okay, and also we have to ask about TB history in the family, which is very important. Whenever a child with respiratory infection comes, we have to ask about contact with tuberculosis. Okay, next slide.
Now, socioeconomic history. His mother is a graduate and she is a homemaker now. Father is a graduate and working abroad as an accountant. There is 6 members in the family. His grandparents, 2 children. That's the patient and that his elder sibling, mother and father's brother. They're living in their own Pakka house, which was terrace 3-bedroom house with separate kitchen and toilet. Waste are disposing properly. Drinking water is from their own well and public water supply. It's using after the boiling. There is no pets, no overcrowding, using LPG for the cooking, and the family belongs to an upper middle class family.
Okay, what are the parameters that you look to calculate the socioeconomic status of a as per Kuppuswamy scale? What are the parameters that you look to come to this upper middle class, lower middle class, and all? Okay, education, occupation, then
Income.
yeah, education, occupation, and per capita income. Okay, go to the next slide.
Now, summary of the history. 1 year and 8-month-old boy, second born out of non-consanguineous marriage, belonging to upper middle class family with an uneventful antenatal, natal, and postnatal life, with adequate nutrition and age-appropriate development and immunization, using glasses for the vision. Now presented with cough and running nose for 4 days, high-grade fever for 2 days, and noisy and fast breathing for 1 day.
Okay. So, any doubts after the history? What does everyone think about the diagnosis? What is the provisional diagnosis? Can someone type the provision after the history? What do you think is the provisional diagnosis in this child? Not the final diagnosis we can get only after the examination, but with the history, if a child comes with this history to you, what will be your provisional diagnosis? Pneumonia, LRTI, LRTI due to viral infection, viral upper respiratory infection, viral pneumonia. Okay, proof URTI. Till where is upper respiratory and from where is lower respiratory? From where does lower respiratory start? Larynx. Pneumonia, bronchitis, post-viral, pharynx, upper respiratory. Okay. So this child, some of you think it is upper respiratory, some think it is lower respiratory, some think it is pneumonia. Somebody who has written as pneumonia, why do you think it is pneumonia? Why do you think it is pneumonia from the history? What are the points in favor of your provisional diagnosis of pneumonia? Very good, fast breathing. Then high-grade fever, not necessarily a reason to say it is pneumonia. Fast breathing is one reason. Then I think she mentioned first in the history there is some indrawing. Okay. So fast breathing and indrawing maybe can give you a clue that this could be pneumonia. Now proceeding to examination. Unaisat, examination.
Now going to examination. First of all, general examination. Child is alert but irritable. There is some subcostal distractions present. IV cannula present on the right hand.
Okay, continue.
Moving to the vitals. Pulse 100 per minute regular. Normal volume and character. All peripheral pulses are equally and bilaterally palpable. No radiofemoral delay. Blood pressure 86 per 60 millimeter of mercury in right arm sitting position. Temperature is febrile, temperature 36.8 degrees Celsius in axilla. Respiratory rate 30 per minute abdominal thoracic. SpO2 is 98% in room air. Capillary filling time is less than 3 seconds.
What do you think about the respiratory rate? Is it normal for this age or fast, or any comments about the respiratory rate?
It's normal.
Yes, normal. What is the, when do we say it is fast breathing in a child of 1 year and 10-month old? Okay, above 40. Okay. Okay, Unaisat, next.
Now moving to the head foot examination. Head to foot examination. Head is normal. Anterior frontal is closed. No overriding of sutures. Hair is normal. There is no dysmorphism of face. There is no dysmorphism. Eyes and ears normal. Nose, mucoid discharge present. There is no nasal firing. Oral cavity, which was normal. Good oral hygiene. Temporary teeth present. Palate normal. No cleft lip or cleft palate. Neck is normal. Chest shape normal with subcostal retractions present. Upper limb and lower limbs normal. Abdomen normal shape, no visible peristalsis. External genitalia normal. Spine normal. There is no tuft of hair. Skin is normal.
Okay. Next. Next.
Now moving to the anthropometry. Weight, observed weight is 9 kilogram. Expected was 10 kilogram. It was it lies between the -2 standard deviation, which was found to be normal. Height is 78 centimeter. Expected is 87 centimeter. It lies between -2 and -3 standard deviation, which is interpreted as moderate stunting. Weight for height is lying within the 2 standard deviation, which is also normal. Head circumference is 46 centimeter, with expected is 48 centimeter. The head circumference lies between the 0 and -2 standard deviation, which was normal. Mid-arm circumference is 14 centimeter, which we are expecting is more than 13.5, which is normal. Upper segment and lower segment ratio, that is 1.5:1, that is normal.
So, any comments about the height of this child? That is the only abnormality in this. Yeah, go on to the growth chart. Yeah, this is how you have, if you are allowed to take the growth chart inside, you have to plot on the growth chart. You can take the growth chart for the exam and you can plot the weight for age, height for age, head circumference, then the height, weight for height on the growth chart. Okay, so why is the height a little bit less? Yes, could be familial because the weight and weight for height are normal. It could be familial also. Okay, when do we say there is severe acute malnutrition? What are the criteria for saying severe acute malnutrition? What are the criteria for saying there is severe acute malnutrition? Can someone type in the chat box? Mid-arm circumference less than. Sorry.
Less than 12.5.
12.5 or
Hello,
11.5?
severe 11.5.
Severe acute malnutrition is mid-arm circumference less than 11.5. Then what else?
11.5.
Then what else? Visible wasting is then
Pedal edema.
edema.
Bilateral pedal edema.
Bilateral edema. Okay. Carry on. Next. Next slide. Okay.
Now developmental assessment. Gross motor. He runs.
Actually, in this style, it is not very important. Just for completion's sake, we have she has included it. Actually, if there is some developmental delay, you have to do this developmental assessment in detail. Okay, this is actually not necessary in this patient, but for completion and for fully knowing, because there is a vision issue, we are doing all this developmental assessment. Okay, Vanessa, carry on.
He climbing the stairs with 2 feet per step. And if fine motor, he makes 3 block tower, scribbles, drawing the vertical strokes and feeds itself with a spoon, and he's right-handed. In language domain, he's saying around 10 meaningful words. In social, he follows the orders and pointing some body parts. His developmental quotient is more than 85% in all domains, which is normal. Vision is he using the glasses and no squint or ptosis. His distant vision is intact with the glasses and near vision is also present. Hearing is normal.
Okay, thank you, Anuna, for putting all the criteria together in the chat box. That is the exact criteria for severe acute malnutrition. Okay. So this time developmental quotient is normal. How do you calculate the developmental quotient? How do you calculate the developmental quotient? Okay, Vanessa, you can tell. I don't think anybody is typing. You can tell.
Madam, development the development obtained by the child by we are expecting that chronological age by
Observed development by the development needed for chronological age into 100,
age.
isn't it?
Yes.
Okay. Okay, next slide.
Now moving to the system examination. First of all, respiratory
So
system.
what all positive finding did you get in the general examination? Positive or negative? Whatever important data did you get? One is there was some stunting which could be familial. Then
there is subpostal retractions.
Subpostal retraction, but no fast breathing. Now respiratory rate is normal, otherwise
normal.
And saturation is also normal. No fever also at present.
Okay.
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 Respiratory.
Now respiratory system examination. Respiratory rate is 30 per minute, abdominal thoracic. Now examination upper respiratory tract. The nose mucodistal present. There is no nasal flaring. Oral cavity, we can say good oral hygiene, no dental caries, lips and gums normal. There is 10 temporary teeth present. Palate and throat is normal. Examination of the lower respiratory tract. Inspection. Trachea appears to be central. No chest wall deformity. Chest movements appears to be symmetrical. There is subcostal retractions present. Apex beat is not visible. Moving to the palpation, trachea is central. Apex is palpated at the left fourth intercostal space at midcalcar line. Chest movement symmetrical. Transverse diameter is more than the anteroposterior diameter. Percussion is not done. On auscultation, normal vesicular breath sounds heard on all auscultated areas. Fine crackles heard at the right infrascapular and infraaxillary areas.
Okay. Anyone? One second. Anyone has any doubt in the respiratory system examination? Anything you want to know, or can we move on to the next system? Okay, move on.
Examination of the cardiovascular system. Pulse is 100 per minute, regular in rhythm, normal in volume and character. Blood pressure 80 bar 60 millimeters of mercury in sitting position, right arm. On inspection, trachea central, apex bit is not visible. Precordium shape and size normal. On palpation, apical impulse palpated at fourth left intercostal space at mid-clavicle line. Auscultation, S1, S2 heard normally in all areas. There is no murmurs. Now examination of gastrointestinal system. Oral cavity, good oral hygiene. Lips and gums, normal. Teeth is 10 in numbers, which was found to be normal. Inspection of the abdomen, shape normal. Umbilicus central, not distended. No visible peristalsis or pulsations. On palpation, no local rise of temperature or tenderness. Abdomen is soft, no mass palpable. On auscultation, normal vowel sound heard. Certain orifices and external genitalia normal with bilateral testis palpable. On examination of central nervous system, child is active and alert. Cranial nerves and motor system normal. Sensory system normal. Spine normal. There is no meningeal signs.
Okay. So summarize.
It's a 1 year, 8-month-old boy, second born out of non-consanguineous marriage, belonging to upper middle class family with an uneventful antenatal, natal and postnatal life with the age appropriate development, using glasses for the vision, immunized for age, adequate nutrition, now presented with cough for 4 days, high grade fever for 2 days, and noisy and fast breathing for 1 day. On examination, child is conscious, alert, afebrile. Vitals were stable. Development is up to age and using glasses. Second degree stenting was present. On a respiratory system examination, respiratory rate and SpO2 normal with subcostal retractions and fine crackles heard over right infrascapular and infraaxillary areas. Examination of other systems within normal limits.
Okay. So what is everybody's diagnosis? Can someone put the complete diagnosis in the complete diagnosis, like you would write for exam? Type in the chat box. Please write your diagnosis in the chat box. The case presentation is over. Now, what is the diagnosis? No one volunteering? Pneumonia with LRTA, bronchiolitis, ARI, very severe pneumonia, LRTA, pneumonia, then bronchopneumonia, right side of moderate to secondary to bacterial. Bronchopneumonia secondary to bacterial. That is primary pneumonia secondary to chronic malnutrition. No form of consolidation without malnutrition. Bronchiolitis, allergy. Okay. Very severe pneumonia. As per the national program, what does this child have? As per the national program, what does this child have? There is a national ARI control program. Okay, this child is having acute respiratory infection. There is no doubt about that. Okay, there is a respiratory infection. So, and acute. So, acute respiratory infection, according to the, what happened to the slide share? Okay, according to the National ARI Control Program, what is this child's diagnosis? ARI no pneumonia. Why did you say ARI no pneumonia, Fatima Thenna? What are the points? If you are saying ARI no pneumonia, please type the points in favor. If you are saying ARI pneumonia, is there a category called mild pneumonia? If you are saying ARI pneumonia, the points in favor of that. ARI severe pneumonia, points in favor of that. What are the points in favor of pneumonia? When do you say ARI pneumonia? That is the next question. Only fast breathing is the criteria or something else also? Fever is not in, doesn't come in the criteria. So ARI pneumonia, yes, because there is chest retraction and also the history says there is fast breathing. This child was examined after 1 day of admission. So probably the fast breathing could have settled. Okay, Unai sir, share your slide with the diagnosis. Somebody else has come. Unai sir, I think Unai sir logged out. Did she get logged out?
I think so, madam. Just check.
Okay, so this is ARI. What are the classifications of ARI in this child? I mean, a child 2 months, there are two categories, you know, less than 2 months and 2 months to 5 years. So 2 months to 5 years, what are the three classifications? In the National ARI Control Program, one is no pneumonia, then the other is come to the diagnosis slide. Yeah, there are only three criteria in the, there are only three classifications. And I said, go ahead with the classification of ARI in children from 2 months to 5 years. What are the three classes, three classifications?
For 2 months to 5 years, there is two classes, severe pneumonia and severe pneumonia.
Pneumonia, severe pneumonia, and no pneumonia also. Yeah. Okay. And in less than 2 months,
for less than
confused
2
with
months,
the
no pneumonia, severe pneumonia, and very severe pneumonia.
very severe disease, very severe disease.
Oh, okay.
And in 2 months to 5 years,
Pneumonia and severe pneumonia. There is no pneumonia.
there is no pneumonia also. The pneumonia classification is these two. No pneumonia is always there. Plus what is the latest ARI guideline? 2 months to 5 years, there is
Pneumonia.
no pneumonia, pneumonia, and severe disease. Isn't it? And in young infant, that is less than 2 months, it is
2 months.
no pneumonia, severe pneumonia, and very severe pneumonia. That is the criteria. That is the classification. I hope I am right. In 2 months to 5 years, the criteria is no pneumonia is always there. That is common cough, cold is no pneumonia. Plus there is pneumonia and severe
And
disease.
severe pneumonia.
Severe disease. It is not severe pneumonia, severe disease. It is
Severe
called.
disease.
And in young infant, it is no pneumonia, severe pneumonia, and very severe pneumonia. Okay.
Okay, madam.
So in
Okay.
this child, this comes as pneumonia because there is chest indrawing and fast breathing.
Fast
Chest
breathing.
indrawing and fast breathing. The color of yeah, pink, yellow, and green is okay, fine. The newest criteria is this, what I told just now. Okay.
Okay.
So now how will you manage? You can stop the screen slide share. Someone can say this is now belonging to yellow. So how will you manage? How will you manage? Someone please type in the injection ampicillin, oral amoxicillin. Then what else? Some more answers. Injection ampiclox, injection gentamicin. Hydration, IV fluid. See, you are sitting in a PHC and this child has come with these symptoms and you have diagnosed as ARI with pneumonia. What will you manage? How will you manage in the PHC? Okay, you have looked for the danger signals. There are no other danger signals, and you have seen that there is fast breathing and chest indrawing. Now what will you do? Then hypoglycemia, all that is okay. Then there are no danger signals. Okay, you are sitting in a PHC. You cannot do a chest X-ray. I'm asking about sitting in a PHC. You are a family practitioner sitting in a peripheral health center. What will you do? Nebulization if there is wheezing. Nebulization is advised only if there is wheezing. Otherwise, start parenteral antibiotics and observe. How do you do that? You have no facility for admission. So, fever control, okay. Unesat, please tell the correct answer.
And for 2 months to 5 years, if this patient has pneumonia, we can manage home
Someone has
management
written
can
very
be
clearly. Yeah,
home
someone has
management
written very
can
clearly. Be given. Can manage an OPD basis, explain danger signs, give oral amoxicillin, BD for 5 days, arrange follow-up in 48 hours, reassess. Very good. Someone has written it fully in one answer. That is, isn't that the right answer?
Yes, madam.
So you have to give oral amoxicillin for 5 days, explain the danger signals, and
Danger
then
signs,
assess, arrange for follow-up in 48 hours, and then reassess. 48 hours or 3 days, 2 to 3 days is what we say, and then reassess. Okay, when you say an answer, you have to be complete. What you do when you are sitting in the PHC. Okay. Then, suppose this child had very severe disease, that is some danger signs were there, some convulsion or lethargy or vomiting fits. Then what would you have? What you would have done? That is very severe disease. That's what you would have done.
We have to admit the patient and give
So you are in a
start
PHC. You are in a PHC. So
okay.
you will give the first dose of
IV antibiotic and refer
antibiotic
to
and
the child.
okay. That which antibiotic will you give first dose?
For benzyl penicillin or ampicillin plus gentamicin.
Okay.
For first
And then
5 to 14 hours.
Okay. And if these are resistant, you can give ceftriaxone also.
Ceftriaxone.
And give and refer to the higher center.
Higher center.
Okay. Okay. So what all advice will you give to the mother when to return? What are the danger signs you will explain? We have already gone through that. When still, what will you explain to the mother? When should the mother return?
Any convulsions, high temperature
Okay.
or hypothermia, or any stridor, then baby is lethargic and not able to drink or feed.
Okay. So suppose this child goes on with mild cough for 2 weeks, then what you will do?
Mild?
Cough is persistent for 2 weeks.
We have if cough is more than 2 weeks, we have to rule out the tuberculosis.
Yeah, we have to evaluate for two things. One is
Evaluate
tuberculosis,
for
and the other is asthma. Yes.
asthma, bronchial asthma.
So TB, and if the child a bit older, asthma also. So 14 days cough, always you have to assess for TB or asthma. But in this child, sputum FB may not be possible because the child will not expect it. But you have to refer to a higher center for tuberculosis and asthma assessment. If the child had wheezing in the beginning, what else management you will give? Somebody already mentioned
Nebulizations.
that nebulization has to be given initially and then assess the child. When the child came, if the child had a breathing difficult, wheeze, then nebulization has to be given, and only then we will reassess and then decide on which category the child falls into. Okay. Now, what nebulization will you give in this child? And how?
For Western, we can give salbutamol nebulization.
Okay.
Mm,
If nebulization not present, okay, what will you give if nebulization is not present? The nebulization you have to give salbutamol, yes, right? Then what? Someone has said that a question was asked to her: what if nebulization is not present? If nebulization is not available, what will you give? Adrenaline is for what? When do you give nebulized adrenaline? Is for what?
Croup.
Croup. It is for croup. Nebulized adrenaline is for croup. So if there is no facility for nebulization, you can give MDI with spacer and also oral. Oral is not so effective. Oral salbutamol can be given. That is what guidelines say. According to the program, oral salbutamol can be given. Even that is what we usually say. Oral salbutamol can be given if nebulization is not available. If an inhaler is available, okay, MDI with spacer can be given. But best option is nebulization. Then comes oral and then MDI. Okay. So, any doubts? I think case presentation very well done. Now, if anybody has any doubts, please post in the time is also up, I think. But if anybody has any doubts regarding any case presentations, please post in the group in the chat. No doubts? So, I think Vishnu, we can end the discussion if there are no. Can we skip percussion in 1 year child? Yes, that is why this child was not percussed. Less than 6 years. Do not percuss. 6 years, isn't it?
4 years.
4 years. Okay, yeah, 4 years. Don't percuss. How to differentiate between URTI and LRTI? So my question is, what happens when the upper respiratory tract is infected? What will be the signs? These fast breathing and chest indrawing and all will not be there in an upper respiratory infection. Okay, only in a lower respiratory. Running nose may be associated with lower respiratory also, but lower respiratory only will have this fast breathing, chest indrawing, all those things. That will not be there in an upper respiratory infection. So what is the difference? Can I ask, what is the difference between stridor and wheeze? Do we get growth charts during exam? No, we have to carry it ourselves. We have to take it. Some exam centers, they permit to be taken inside. Sometimes they don't permit. If they don't permit, we have to calculate using the formula. Okay, my question is stridor and wheeze. What is the basic difference? Strider is inspiratory. Wheeze is usually expiratory obstruction.
Right.
Okay, national program for all these are available. You can just go to the government site for national programs. You will get all these. RMNCH cited. IMNCA also you will get all these things. Better to, when you put a diagnosis, better to put it according to the national program, because you are all family practitioners expected to sit in a primary health center or community health center or a peripheral health center. So you have to be thorough with the national program, how it is managed in the national program. Okay, be it ARI or ADD or whatever. Strider is inspiration and Wheeze is usually expiratory. Okay, I think doubts are over. Can we wind up?
Yes, ma'am. I think there are no more questions. We'll wind up this session. I hope it was a useful session. We had around 75 participants attending. And thank you, Rashmi ma'am, for moderating the session. And thank you, Naisik, for coming up with the pediatric case presentation. Thank you, everyone. And we'll have our next session in another 2 weeks' time. Thank you.
Thank you, Vishnu. Thank you, Nesar.
Thank you.